Hello, my name is Satyajit. I'm professor of HIV medicine and a consultant physician in a teaching hospital in UK. I'm going to present another case today. This time it is about an HIV patient. But the condition the patient is suffering from can be found in HIV negative and also in HIV positive patients. In fact, it is more often seen in HIV negative patients rather than in HIV positive patients. So this case will be interesting for different clinicians of different specialties or different disciplines. With this, let me start with a 26-year-old newly diagnosed HIV positive female patient who presents with high fever, shortness of breath, pleuritic chest pain, dry cough, and hemoptysis for 3 days. Systemic inquiry was unremarkable. She had no past history of medical illness, and family illness were unremarkable. She doesn't smoke cigarette and doesn't drink alcohol. On examination, she was anemic, pyrexial with a temperature of 39 degrees Celsius, hypoxic with oxygen saturation on air 89%. She has generalized lymphadenopathy and liver was palpable but spleen was not palpable. On examination of the chest, she has right-sided pleural effusion with consolidation. Her heart sounds were normal. There was no murmur, no focal neurological deficit. Hemoglobin was low. She has leukocytosis. Kidney function and liver function were within normal limits, but total protein was raised. Serum LDH was raised. Inflammatory markers in the form of CRP was raised. ESR was raised as well. Anti-nuclear antibody was positive and ANCA was negative. This is a chest X-ray and we can see there is consolidation and with moderate effusion. She had a pleural aspiration and biopsy, and the aspirate was suggestive of exudative type, and the gram staining did not show any organism. There was no malignant cells. Pleural biopsy did not show any specific changes and was sent for culture. Several other specimens were sent for culture, including blood culture, urine culture. She had a bronchoscopy which had a normal appearance. Bronchoalveolar lavage was negative for acid fast bacillus or any other organism, including any opportunistic infections. Her serology for hepatitis B, hepatitis C, and other infections were negative, and she was tested negative for COVID. She had a serum electrophoresis and which showed polyclonal gammopathy. She was treated with oxygen inhalation and started with an empirical course of antibiotic and received some analgesic in the form of paracetamol. 3 weeks after admission, she was feeling much better, almost back to normal. Her temperature settled. There was significant improvement in the inflammatory markers, but she still remained anemic. We have got some HIV results. The viral load was high, over 200,000, and CD4 count was 520. And CD8 was over 1800. Patient was not keen to start antiretroviral therapy and she was discharged from hospital with an outpatient appointment. 6 weeks time, she comes to the outpatient. She is well. She has got no further fever, no night sweats, only shortness of breath on exertion, but that is not a problem for her. Her weight remaining same, viral load remaining high, CD4 stable at 480 and CD8 over 2,500. Again, she is not keen to start antiretroviral therapy. Chest X-ray remaining grossly abnormal with consolidation and a possible effusion. She had a lymph node biopsy while she was in the hospital, which showed reactive hyperplasia, which is often seen in HIV patients, not suggestive of any neoplastic changes or any particular infection. At 4 months, patient is well. Patient has got no physical problem except shortness of breath on exertion, but more loss of lung volume. She was not keen to start antiretroviral therapy because she was feeling well. 8 months, patient remaining same, chest X-ray same with more loss of lung volume. At this stage, she had HRCT, and we can see here the changes are quite characteristic. She also had an open lung biopsy, and here is the histology. So the normal lung on one side, and to compare that, the histology of the patient's lung. And this is under magnification of the patient's lung histology. After 6 months, she's much better. No shortness of breath, lymphadenopathy improved. She gained in body weight, chest X-ray almost back to normal, HRCT almost complete clearance of the lesions she had. So, what do you think is the diagnosis? What treatment she had? I can only say that she did not have any AIDS or AIDS-defining illnesses. I will also urge you to share this video with your colleagues, particularly radiologists and histopathologists. I have got several cases of this type or different other types, which I am considering to post in YouTube channels. And in the meantime, please feel free to comment, share your views. It is not a question of right or wrong diagnosis. It is your participation which is most important. I look forward to see your response, and I'm going to present a follow-up video very soon where I will reveal the diagnosis and discuss a bit more about this condition. And if you have already subscribed this channel, that is fine, or you may consider subscribing this channel and press the bell icon so that you can get a notification as soon as my video is posted. Thank you very much. Wait for the next video. Bye for now.